Hello, everyone. We've got some disclosure slides we'll let you take a look at here. My name is Dr. John Burleson. I'm a spine surgeon out in Nashville in my first year of practice. We're very excited to have everyone here for our inaugural meeting tonight. Mainly, this course in general is designed for all of you. We put this together so that young surgeons would have a forum by which we could talk about issues that maybe aren't suited for case studies with surgeons from around the world, which seems to be all the meetings we've been having over the last year. So our goal here is really to talk about everything throughout the series, from finding the right fellowship to board preparation, how to use social media in medicine, what is it to consult for a device company, what's legal, what's ethical, when should you do that, how do you build a practice, hire staff, things like that that maybe don't get covered in every episode of training because we're busy learning how to be surgeons. Our hope is that this course as a whole really acts as kind of a smoothing process whereby we can share our strengths with other people that might have a weakness in that area, and we all get the crash course from the representative residencies and fellowships we went through, so that residents, fellows, and basically attendings in the first few years can kind of learn from each other's mistakes and triumphs and replicate those. So first and foremost, I want to say we have the chat function in the bottom if you're not familiar with that. At any point during the talk, if you have a question, put it in there, and that way we won't forget it before the end. The structure of these meetings is going to be a little different than the average meeting. I have a really short attention span, so it's basically built around that. We're going to do a 20-minute talk, a 20-minute talk on something different, and then 20 minutes of question and answer at the end, in which case, anyone is welcome to ask a question. So for tonight, we're going to get started with my two co-chairs for the course. So the first thing we're going to have is Dr. Hobson, who brought Dr. Weinberg with her, and they're going to discuss choosing an academic practice for your career. And then we're going to have 20 minutes with Dr. Webb, who's going to give kind of the counterpoint, and he's going to discuss choosing a private practice for his career. And then at the very end, like I said, we'll have a 20-minute question and answer where no question is too dumb. You ask anything you want. We're here to kind of learn from each other. So with that, I'll hand it over to Dr. Hobson and Dr. Weinberg.
All right, everyone, welcome. I'm going to start sharing my screen. Well, good evening, everyone. Thanks for joining. My name is Sandra Hobson. Like they've said before, I'm an assistant professor, assistant residency program director at Emory University in Atlanta, and we'll get us started with talking about why I like academic practice and why I ended up choosing it, and what you should think about when you're working through choosing your own practice. The learning objectives officially for this talk are to understand the difference between private and academic practice, as well as to understand the various practice models after finishing training. So my disclosure, this is mostly, is that I'm an academic surgeon. That's me there. So obviously my side of the talk is biased towards academic surgery. And then I reviewed here. So I completed my fellowship now last year, 2020, thankfully it's last year. And I started my academic practice in September of last year at Emory. And then to get us started here, so if you are in medical training, I feel like you go through medical training, you complete your undergrad, you complete your medical school, you complete your residency, you complete fellowship. And throughout a lot of that process, the trainee has very little agency. So you often have very little true choice in the matter. You know, you participate in match lists and rankings, and flexibility is a great mindset because once you're matched, you're going where you're going. And it really changes when you start to look for your job, because for the first time in, I think, over 10 years as a trainee, you finally have a significant amount of agency, and what you do really has a lot of impact. And looking for a job is very different than a residency or a fellowship match. So on this note, one of my colleagues, who's a few years ahead of me, to me and said, I love my job, love my partners. I'm not sure I like living here far from my family. We don't want to buy a house because it seems like it's admitting that we'll live here for the long term. And I feel like that's what leads me to talk about looking for a job and choosing between academic and private practice, because I think really the question that a lot of people say is, what kind of job should I have? But I think another question you should think about is, what kind of life do I want? And I think you should design your career around your life and what's important to you overall, and not necessarily the other way around. I think making a value-based career decision is what I recommend to everyone who calls me and asks for a one-on-one conversation with what they should do with their career. And I think you should first ask yourself, what do you want your life, personal and professional, to look like for the next 30 years while you're working? And I think personal life and personal relationships are often neglected during medical training when people put in long hours during medical school and residency. But they shouldn't be neglected when you're thinking about your next phase in life that hopefully will last you for 30 years. So I'd first like to say, make sure you appropriately factor in your personal relationships in your decision, and then be honest with yourself and who you care about what's really important to you. And so with that in mind, I think, when you think about different things that could be important to you as you look for a practice and a job, one of my mentors told me that there are three key things when you look for a job: location, practice type, and compensation. And you can almost always have your favorite one, but you can rarely have three. So it's important for you to think about which one is most important to you. Is it location? Is it being close to family? Is it being far from family? Is it big city? Or is it truly practice type? You really want a big academic or a private job, or compensation. So to talk a little bit about academics, so academics and location. So often, not always, academic institutions are located in larger cities. So you're often looking at living in a larger city. There's a little more limiting. There's not always a job available in a specific city in a specific year if you're graduating from fellowship and looking for a specific job in a specific city in academics that year. And then there's often only one or two, with some exceptions, big academic groups per city. So if you're looking at being in a specific city and location is very important to you, you should be aware that if you're interested in academics, you might only have, one, possibly two groups that you could join to remain in that location. And then for practice type, I hope everyone knows that academics is a very, very, very broad term. There's many different subtypes of practice types within academics. And I'd say the big two categories are kind of the big house academic practice and then the satellite site academic practice, which is sometimes now called more a private-demic model. So the big house model is that your practice is based at the flagship hospital. So you are at the big center. You're typically working with high-level trainees such as residents and potentially fellows, depending on your specialty. And you're talking about spine, so it just depends on whether the academic center has fellows that you're working with. And this is in contrast to being at a satellite site, which academic universities often purchase or acquire smaller hospitals that are satellite hospitals. They're offering jobs, hospitals where you have a professorship or an affiliation with the university, but your academic duties can vary. So you may not have residents, you may work with a PA, you might not have a research requirement, and these variable. And as you look through an academic practice, it's to keep in mind that just like private jobs, no academic job is created the same. And if you are looking at mix, I do think it's important to look at these opportunities and see, do you have an opportunity to participate at the flagship university where often more of the research and more of the collaboration is going on, or is it more of a satellite position? And then compensation, I think it tends to be a little different than private practice. It is often a little bit lower in gross dollar amount than private practice over a surgeon's total lifetime. I do think there's a little bit less financial risk assumed than traditional private practice, where you own the practice, potentially have to buy into the practice. In academics, it's a bit more of an employee model than an ownership model. And in academics, you can be paid anything from 100% salary. So there's no productivity component to your salary whatsoever. You just get paid a salary every year. compared to an academic practice where it's 100% productivity based with no base and no salary. And then there's everything in between. And so this adds another variable to the academic practice model. Then in addition to just salary, academics has a lot of different things that I would consider valuable. And they might not be compensation in terms of dollars, but those could be things such as research funds, a physician assistant that is provided to you at no cost to you, things such as academic days. So you have a day where you're not doing clinical work, where you're doing research or education events. They might provide travel funds for you, CME funds, vacation days, access to research equipment, and associated costs. So if those things are valuable to you, even though the salary could be less, they could provide things that provide compensation in other ways. I would strongly encourage you, if you're interviewing with any job, private or academic, but make sure you understand the compensation model, because I would say they can be highly complex and highly variable in academics as well as private. So it's very important, in my opinion, to make sure you understand the compensation model. And then another thing in academics that sometimes ties into compensation is make sure you understand the criteria for promotion and performance. So in academics, sometimes you start out even as a clinical instructor, and other times you start out as an assistant professor, typically if you're coming straight out of fellowship, depending on the university you start with. And then advancement professionally often requires a promotion to associate professor and then full professor. And most universities have detailed, long documents on what's required for promotion. And so if you're interested in a long-term career in academics, understanding what the university expects of you, understanding what the department expects of you, understanding the different tracks for promotion, I think is critical before accepting an academic job, because if it's not something you're interested in, the things that are required to be promoted, maybe it's not a good fit for you. And some other unique components of academics, I think in private practice, you certainly can do research, but I think in academics, there's certainly more opportunities and more facilities to do research. And I think there's more opportunities for collaboration with other disciplines and other specialties. I think there's more opportunities to teach high-level and motivated trainees, such as fellows and orthopedic residents. I think in private practice, many people can still be involved in education in the community, education for students, but I think academics still allows people to participate in training of spine fellows and orthopedic residents more so than private practice. I think compared to private practice, academics does have less autonomy and more rules. So if you're in traditional private practice where you have part ownership, you certainly have a lot more authority over decisions and what you do on a day-to-day basis. So in academics, oftentimes you're buying into the mission of the university and you're participating as one person as part of this university. And so there are pluses and minuses, and I think you trade some of your autonomy as part of that deal. I would personally say there's a slightly more immediate referral base if you're a junior partner. And again, it all depends on where you go in private practice. You might have an immediate referral base depending on the practice you take over or join. But many people will come to a university looking for care there for many reasons. And so they'll be referred to you just based on referral from the academic center. We talked about the salary issues, and I would say that your work life is a little more variable. I think in private practice, many people do spend a lot of time on patient care, which is great. And in academic medicine, you do typically have a few more demands on your time, such as research and educational expectations, whatever that might be. And then lastly, I wanted to comment on I think it's easier to transition from academics to private practice than the other way around. And I'm not sure there's a definitive explanation for that, but I think it's something that people should be aware of when they make their choice. And so then just a little bit about me, why I personally chose academic practice. I think in my work, legacy is the people and having well trained. I really enjoy teaching and I really enjoy mentorship. And I also love challenges. And I think, I don't know if some of you have experienced this as a resident teaching other residents, but I think that teaching someone else to do something is like 10 times harder than doing it yourself. So I personally really enjoy that because I think it adds another level of complexity. And also, the job that I chose, I thought it provided an opportunity for a complex practice quickly. My second case was a posterior C1-2 fusion and a DINS fracture dislocation. So, to me, I thought that was an exciting way to start off, and it was kind of the challenging career that I wanted. And then additionally, opportunity for research and access to facilities. And then when I looked at my three things that were important to me, I was very strongly leaning towards academics, but not at all costs. I did want a place that was suited for me personally and ideally in a larger city in the Southeast. And I was very thankful to be able to have a fit with the role that I have now. And then I'd like to introduce our special guest, Doug Weinberg. I'm only one person in academics and I have only one job. And there are many different practice types and opinions about academics. And I was hoping Doug here could chime in on his thoughts.
Thank you, Sandy, for the introduction. And I think overall that's a great overview of academics and looking through the job search, which is always very daunting. One thing that I would add is, I personally was always interested in academics, but I think it is important to consider both options. And for people that are online that maybe really have their heart set on one direction or the other, at least explore the other. And I think that you'll learn a little bit more about the process and especially just, educating yourself on some of those nuances in terms of the compensation plan and contracts as well. Just to build on a few things that Sandy said, I think that academics does have a lot of advantages. The referral network is in a lot of settings just already built in. You can show up to your first day and all of a sudden your clinic is filled with 25 complex patients and wow, ready to hit the ground running. Whereas in private practice, I think it can be variable, but sometimes it's a little bit harder to build some of those networks and referral patterns as the new guy in town. I also like the idea of taking on and having access to some of those complex cases, which generally funnel their way into the academic medical centers, but certainly are seen in plenty of private practices. For me, though, the real, I think, draw to academics is just the interpersonal relationships and the people that you meet along the way. Both people at your own level, colleagues, such as the panelists that we have on this talk, but also those mentors that you have above you, and at this point now that I'm starting to be responsible for training people. I think that just some of those relationships and friendships are really cool and fun. As you keep track of people throughout the process, you go to meetings and you watch someone grow, and maybe you can say that you had some kind of impact on their career. And of course, we all have plenty of mentors above us that our relationships with them grow as well. And for me, just kind of those kind of interpersonal friendships and connections were really, really valuable. I know it sounds cheesy. The other draw to academics along the same line is I think there's a little bit more of a camaraderie of being at that big house where there's a lot of kind of fun, cool, interesting cases going on, and the room right next to you, they're doing some kind of cutting edge thoracic surgery or something like that. That's definitely seen in a lot of the private environments and definitely a lot of the private academic areas. But for me, I just like the idea of being, at a more centralized area where some of the, bigger things are happening. But again, I think the most important thing is to just be open to both. As Sandy mentioned, of all those three things, it's very hard to find a position that has all three. And if you are really just tunnel vision towards private practice or tunnel vision towards academics, you may find that you end up getting boxed out of a good opportunity.
Thanks, Doug. Really appreciate all your thoughts. So in summary, my thoughts on academic practice are always make a value-based decision for your career and life, considering both your personal life and your work life, and never make it about just a question about what's the right job for me, but what's the right way my job is going to fit into my life. Consider location, practice type, and compensation, and try to decide for you which is most important and why, and then use that, like Doug was saying, to help evaluate different opportunities as they come up, whether they're academic or private, and wherever their location and compensation might be. And then ultimately, each practice situation, whether it's academic or private, is still unique within those two subsets. And then just make the best choice for you. I think people can have very fulfilling careers in academics and private practice, and it's more about a fit that you feel is good for your life and your work for the next 30 years. And thank you, Bilal, for sending a question in the chat. I saw it, but I think for now, we might hold off on answering questions until we go through Dr. Webb's talk, and then we'll open it up for more questions. Sound reasonable?
That's perfect. So next we have Dr. Webb, who's in private practice down in San Antonio in the great country of Texas.
All right, so let me share my screen. I think you have to stop sharing, Sandy. Let's see.
All right.
There you go.
You ready to go?
All right. So a great job by Sandy and Doug. They really broke down and made academics look really kind of appealing for a lot of people. I'm gonna go over academics. I am an orthopedic spine surgeon in private practice here in San Antonio. I'm in a fairly large group. There are 10 spine surgeons, one general orthopedic surgeon who used to do a lot of spine in the past, and we have about 5 to 6 PMR physicians. We have physical therapy department, DME, and also a surgery center. This is a little bit about my background. I went to college here in San Antonio. I was in the military for 8 years prior to medical school, and then went to medical school. Did my residency here, and then a Texas Back Institute for my fellowship. Let me go back. So I'm gonna go over when to decide, some pros and cons, and kind of why I decided on private practice, and also some tips for everyone. I think I get this question a lot. When do you have to decide what path you want to take? I think it's never too soon to decide. I actually started during residency. I knew I wanted to come back to a location such as Texas, and Sandy kind of touched on that. You need to figure out location, kind of whether that's South or West Coast, East Coast. That will help you narrow down which groups or which hospitals to reach out to. And I think you need to figure out what's important to you. And sometimes this comes, over time. When you're a 50-year resident, you're talking to other people, your chiefs, the young attendings. This is how you can figure out what's important to you. So you should talk to your mentors, talk to senior residents. I can't even count on, 2 hands how many people I have called to get their advice about practice models after of training. So definitely use your mentors and just pick their brains, especially the ones who have just went through the process. I think your decision will help you narrow down potential jobs, and whether that is academics or private practice, that decision will help you narrow it down. But I think it's okay to apply to both. I actually met with probably about 6 or 7 groups before I even started fellowship. So I just started the conversation. Hey, I'm thinking about coming back to town, just to put it into their head. And, I met with all of those groups before I left, and then continued that during fellowship. But I think it's important to have a plan. So private practice, there are some pros and cons. I think some pros of private practice, you have more control of your practice, as Sandy kind of mentioned. The downside of that is that if you don't work, you don't get paid. So especially during the COVID pandemic, where a lot of practices are being affected, if you take 2 weeks off in private practice, you will not have those 2 weeks of paycheck. So it's not like academics where you may have a salary that's somewhat guaranteed for you. In private practice, it's most models are eat what you kill. I think the earning potential is greater in private practice, but on the downside, you have more fluctuations in your income. 1 month you may collect $100,000, the next month you may collect $30,000. So it depends on the time of year. It depends on how busy you are during that time. A lot of the things that you do in private practice, 1099. I'm a 1099 employee, so a lot of the things that I do are business expenses. That's a pro. But you do have less academic responsibility. So the time that the academic surgeons are spending doing research as well as teaching, well, we don't do that as much in private practice. Although I will speak on kind of a mixed kind of model that you can do. It's called pracademics, but we spend most of our time seeing patients and operating. So I don't have a day of dedicated research, although I still do research. I'm actually writing a few articles. I just joined the publications committee for a journal here in town. So just writing some articles for that journal. And I still do some teaching. I just gave a lecture to the residents here about cervical myelopathy. And then I have some medical students that just come through and hang out. So I get a chance to do some teaching that way. So even though you're in private practice, there's still opportunities to do teaching as well as research. On the downside, you have less manpower. So when I was a resident, there was plenty of other residents that can give you a hand, hold retractors. I'm still doing some general orthopedics until I get busier. So today I was doing a knee replacement and I had a first assist that helped me. So I didn't have a resident or intern that can just say, hey, hold these sticks here. I had a first assist, but that's kind of one of the downsides of private practice. I have 2 hospitals I have to go around at tomorrow. I have to do that myself before my clinic. So I don't have a resident or I'm not busy enough to have a PA. So it's just me doing the rounding, putting all the orders in and those things. Pracademics, this is private practice within academic appointments. We are currently in the process of trying to obtain this. And you can still do research and give lectures. So I plan to give some grand round lectures to my residency program here, to the students and to the residents. So you can have a combination of both. And that's how I kind of envision kind of my practice model is kind of more of a pracademic type model. I still like to go to some meetings and do some research, present at meetings. So that's kind of how I envision my model. So I think why I decided on private practice, I think the number one thing was location. The second thing was overhead. So that's something you really have to pay attention to. I have a friend who is 4 months into practice and he just had his contract terminated. So that quote that's out there, 50% of people leave their job in the first 2 years, that's certainly true. And I see that to be true. A lot of times you just don't know what you're getting into. When you think you may know a practice or you think you may know the surgeons or the other groups of doctors that you're joining, but you really don't know until you get in there and start working and start, starting your practice. But for me, I eliminated 90% of the groups because of the overhead. Some of the groups wanted me to pay $50,000 a month. There's one group that I didn't interview at, but I have a friend who's currently at, and he's paying $60,000+ a month. And I just starting off in my practice, I see that you have to do a lot of surgery. You have to see a lot of patients to even generate $50,000 a month before you can start taking something home. So most of the groups that I eliminated, this may not be a good reason to do this. I don't know, but it's something that I decided that some of the groups that their overhead was $40,000, $50,000, I eliminated those groups. But I think for private practice, the group that I joined, it was more of an aging group. These are the ages of the surgeons that are in my group now. The oldest one is 71, and he's still very busy. 65, 63. The average age is 54. So I saw that there was a lot of opportunity to kind of grow and expand over the years. Most of the surgeons in my group will probably be retiring within the next 3 to 5 years. You have the ability for ancillary. So this is any braces that you sell, physical therapy, neuromonitoring, first assist. There's investments in surgery centers, commercial real estate, as well as the opportunity to do product development and consulting for a lot of companies. But I believe, and maybe Sandy can touch on this, that if you're in academics, a lot of these things are kind of limited in terms of what you can do, as well as if you develop something, there's clauses in your contract that may limit your intellectual property rights. So that's something certainly you have to think about. So my advice would be to talk to your mentors, as well as once you're in practice. The most invaluable thing that I have seen in these last 4 months is being able to operate with my senior partners. That's been the most invaluable part of my training thus far, being out in practice, is just doing these bigger cases, seeing what companies they're using, what implants, which hospitals, why are they choosing certain hospitals, the ability to learn from them in terms of coding and in documentation. Those things are invaluable. So that's another reason why I eliminated a number of different groups, because I would have been the only spine surgeon in that group or in that area. And I come to realize that's probably for most people, even though you may feel like you're very confident coming out of training, you get out in practice, it's a whole different ball game when you're doing these big cases by yourself. And some people may be able to do that, but for me, I'm still learning. Did a big case yesterday, and one of my senior partners helped me. And I think it's just invaluable to just have someone there to help you when you're getting started in your practice. While you're a resident, whether you're neurosurgery or orthopedics, I think it's important to learn how to be a good orthopedic or neurosurgeon in your residency. I was very, trying to do a lot of spine cases during my residency. I should have been just focusing on trying to be a good orthopedic surgeon. Those good skill sets that you learn, those things will definitely help you when you're out in practice. I think it's important to start your search early, whether, that's, if you want to go to a certain location, start meeting with people, just telling them, say, hey, a couple years from now, I'm doing the fellowship, I would love to stay in touch with you so that maybe we can possibly talk about joining your group or your practice once I'm done. You just need to let people know that you're interested in staying in certain locations and what your interests are. And then interview often as well as many places as possible. Every place that I interviewed at, I learned something different, and I learned something more about contracts. If you want to stay in Atlanta, Georgia, interview at every single group there. That way they will get to know who you are. And secondly, you'll learn certain things about their practice that you may not have. You get an inside look about what they're doing and where their clinics are. How many days, how often are they operating? How busy are they? So I learned these things by interviewing at all the groups here in San Antonio. And I got to know a lot of different surgeons that way. I interviewed at some neurosurgery groups here in town, and just to see the different practice models. And then most importantly, I think it's important to enjoy the ride. This is, you're in training for so long, and then you're able to get out and practice and do some things on your own. It's definitely been a blast this last 4 months, and just happy to be done with training. But this is my contact information here. All of my social media accounts are Antonio Webb MD, and happy to take any questions.
Sweet. Thank you, Dr. Webb. Dr. Hobson, do you mind answering Bilal's question? If you could read that to the group and then answer that for us.
Absolutely. Let me bring it up in the chat function here. So Bilal, hi. Nice to see you on the panel or the webinar here. So his question is, do you think something is lost in going straight from fellowship to academic practice? In a few days, you go from being the trainee to the trainer. So I think that's an excellent point. And I think it's well known that medical training is marked by these stepwise progressions. So one day you're a medical student and the next day you're a doctor. And one day you're a resident and the very next day you're a fellow. And one day you're a fellow and then the next day you're an academic spine surgeon. And the question is really what makes you qualified to advance? And I think that's a complex question that goes into a lot of different things about medical training in the United States. But I do think that for the person who's prepared, for the person who's well trained, there's still something you can offer. So certainly as a junior attending, so for me, I'm only 1 year ahead of the current fellows at Emory. And certainly you could say, I think I have a few things I can teach them. I think there's also things I can learn from them. But I think we can certainly complete cases together. And for example, today I did a case, I did it with the PGY2 resident. I think it was valuable. I think he learned some things. I think we completed the case safely and successfully, and the patient's doing well. And I think, you do potentially miss out on the times where you just get to sit alone and, do the case with the first assist and do everything by yourself. But I think to me, it was the type of practice that I wanted to have. I think coming right out of fellowship, if you just worked by yourself with the first assist or PA, I do think it's one less variable to have. I think one of my first few cases, I did a case with a resident and a fellow, and my NP was checking in. And so stepping into a role where you're managing a large team with multiple players, I think is challenging. But I think for someone who's interested in academics, who's interested in teaching, certainly I think the beginning of that transition is probably the hardest. But I hope that over time you have more and more to offer people. And like Dr. Webb was saying, you also have your senior partners who are there for you as well and there for the trainees as well. And I think there's something that residents and fellows can learn from senior partners and junior partners. Did that answer your question, Bilal? I see you were added to the panelist side, so I think you can join in the conversation.
Yeah, no, thank you. That answered it perfectly. I think my thought process is a lot of our joint attendings here at the University of Michigan, they were mostly private before they became academic. And they said that they never had a chance. Well, by going private, they were able to develop their skills of what they liked in operative flow and kind of compiled all their years of training into saying, hey, this is how I want to do this case. And then now they're able to go in and then teach a resident like, hey, this is how I do my ACDF or how I do my total hip versus, oh, hey, I'm just kind of picking and choosing and never kind of compiling, this is how I should be doing it because I feel most comfortable. But I think you answered it great. Thank you.
Yeah, that's a great point. And also with you echoing what you said, Sandy, I interviewed at an academic position also. One of the things that I mentioned and made sure that when I was interviewing there is that I would not have a resident for, I don't know, the first 6 months or the first year. So maybe Sandy, you can speak on this, is that when you were interviewing at these academic positions, were you able to tell them, say, hey, I don't want a resident, I want to figure things out? Because this whole first year of being out in practice, you're figuring out your protocols, your post-op protocols, and how you manage patients and how you treat patients and your overall operative flow. That can be challenging with a medical student or a resident that's in the case with you.
So I'm not going to say it's not challenging. I think those are very good points. And I think certainly the more consistency you have, the more predictable you can make a situation. So oftentimes I'll go into an operating room and there's a resident there that I haven't worked with before, and there's a scrub tech there that I haven't worked with before, and there's an anesthetist and anesthesiologist. Well, maybe I've usually seen an anesthesiologist, but there's an anesthetist that I have not worked with before. And I do think that does add variability, and it does make it a little challenging because you have the same conversation multiple times. I think it does take somebody who's committed and interested in teaching and training people. I do think it takes a little more time to develop that just absolute consistency that you have. And, I've only been in academic practice for a few months, so potentially I'll have some more insight once I've been in academic practice for a year or two. But for me, I personally have still found it great. I I find that I really love working with the residents. I think they're highly motivated. They really care about the patients. So to me, the trade-off is worth it. I do certainly see your point though. But for me, I think I take some of those struggles on working with new residents each time in stride. And I think for our program, we have 6 residents a year. So you start to work with the same residents over and over again. And you work with the fellows as well. And you kind of get to know them and, you know, what they're good at, what their skill level is. And you can go from there.
And let me just quickly chime in. I was going to let everyone know, I forgot to mention this in the beginning. When we go to the Q&A part like now, we basically port everyone over to panelists. So if you turn your camera on, you can ask a question over there. Certainly you can ask it in the text box as well. But this is kind of more of the informal part where, you know, we don't know everyone here, and we, you know, all of you guys are our peers separated by a few years. So it'd be helpful to ask your question in person if you have one. I'm just going to get to the next question on here, where I thought it was a pretty good point. Stephen brought up, you know, we were mentioning that it's probably more difficult to go from private practice to academics than the other way around. And I think Sandy mentioned that. And in general, I think that's a pretty accepted truth that, you know, my opinion was always maybe it's a little bit of the relationships that you build, or it's kind of like an inner circle from your training. Oh, well, last year I trained with this guy or girl that knows the people in your program. And it's kind of a helpful thing in academia. But his question is, you know, given what COVID has done with some hiring freezes and academic institutions maybe not doing that, you know, if you're someone who wants to go into academics right now and you're seeing that maybe that job isn't available right now, or maybe you want to be in Atlanta or San Antonio, but the medical school there isn't hiring, you know, what advice or thoughts do you guys have, you know, on maybe Doug, you can answer this, and what your thoughts are on how do you proceed with that? You know, is it okay to be in private practice for a little while? And I'd probably mention wherever you go first, you're going to want to be there through boards or you have to start over, but is that worth doing and then trying to transition? Or, I mean, what are your thoughts on that?
Sure, that's a great point, and you know that I feel like it, you know, can't be said enough that the virus has just changed so many things over the last year, and the nature of contracts and finding, you know, employment is certainly one of them. I think it becomes very, very tough, and to your point, a lot of jobs that used to be available both in academics and in private practice are just not having the same opportunities anymore. Advice that I was given was that it's just going to become a little bit more challenging now for all of us to find maybe that ideal, that perfect fit. And there is no perfect job. And I think that's even more the reason why we should all be flexible during our job searches, considering both private and academic groups. Because I'll say, even if it's not the perfect job, any job is better than no job. And unfortunately, I know that there are always a few people that do get left out in the cold every year because I think they wait a little bit too long and are trying to find that perfect job, that perfect situation that may or may not exist. And who knows what the future is going to hold for healthcare, and maybe there will be another type of COVID or something else comes up that totally changes practice. So I think, yes, it's definitely going to be harder for all of us to find the ideal job. And you know, there's not a single person in this world that hasn't been affected, you know, by COVID, and just, you know, things to keep in mind going forward.
Yeah, and I think, you know, something that's worth talking about, you know, we have a lot of great topics that we're planning on covering through the rest of this year. We're basically doing this talk monthly. And by the way, if you guys out there have a topic that you really think we should touch on, please let us know. But one of the things we're going to talk about is contracts, because that's always terrifying for people. And, you know, the points that you brought up there, Doug, you know, in terms of trying to find that perfect job, you know, that doesn't really exist. I will tell you one thing I've learned from COVID is the way our contracts this year really changed. I mean, Webb and I went through a really crazy process. I'm sure other people did too, about things getting juggled around. It certainly changed the way that I look at liability that I'm willing to take on through the group, the way that I look at the contract in terms of when can I get out of it? I don't want to get there and then them say, well, we're not doing elective cases for a year or whatever. And so you don't have a job tomorrow, and then me be out in the cold, so things like that. I'm looking forward to talking about through the year to look for in the contract, just because it is such a strange planet that we're living on right now. Let's see if we have. So I wanted to ask one more question to Webb and Sandy. So stress was kind of brought up as part of the topics on both sides in terms of where you get your stress from. So, in academics, I remember the vast majority of people train in academics. I was stressed because of red tape that drives me insane. Me talking to someone that felt like I was talking to a wall, that seemed to happen all the time in academics. And then in private practice, the very short time that I've been there, I see less of that. And my stress and anxiety comes from the fact that I don't have the whole system around me, and I can't say, well, that's how we do it here. If there's a problem, I get blamed for it because I'm like the last stop, and I feel like, I was a trainee, one day, and the next day I'm like totally in charge, and that was a little stressful. Webb, could you maybe talk first about where you see stress points in private practice, if it's the same or different, and how you factor that in and how you deal with those?
Yeah, that's a great question. One of the things is what I mentioned is the overhead. That's a big stressor, especially everything that's going on with COVID right now. Starting tomorrow, most of the hospitals that I'm operating at, they're not letting us do elective cases. Well, for spine surgeons, there's patients who may have progressive weakness or uncontrolled pain. You may be able to kind of get away with those cases, but any of my general orthopedic cases, I most likely will not be able to do. So that's a big stressor. But for most people that come out into practice, you have what's called a guarantee. Some hospital or your group will guarantee you some sort of salary. They should during that first year. So no matter if you're very busy or if you're not busy, hopefully you should get that same salary throughout that first year. And hopefully by that time, this whole COVID thing should die down. But that's one of the big stressors. Another thing is, like you said, not having people around that may be able to help you. If you are doing an ALIF at a surgery center and you get into a vessel, well, you may not be at an academic institution that have all these vascular surgeons around that may be able to come and help you. So that's another thing, is just having that manpower and the support. And then the overhead, I can't stress on that more enough. You really need to pay attention to that. You want to keep your expenses really low. That's what I have seen over the last few months.
Well, I can tell you too, something I never thought of until private practice was when they told me I have dictation software on my phone that I can dictate into the EMR. And the good news is I get it free for a month. And after that, I have to pay for it because every expense in private practice is your expense. So I said, okay, well, how much is it? And they're like, oh, it's only $400 a month. You got to be kidding me. It's crazy. You don't realize that these practices that are paying for this, either they're paying for it and you're indirectly paying for it, or you're doing it yourself. And in academics, that was at least one thing that, I just didn't think about. The system bought Epic. Great, we have Epic now. And that's kind of what I use. Sandy, could you talk about some of what you think are the stressful things and being an academic attending now? In your situation, you were there before, and now you're there again in a little bit of a different role after, being gone for a year. What kind of things were stressful for you?
I think anytime you start a new job as a surgeon, you're going to be a little bit stressed out because now you're the one who's ultimately responsible. And I think that's true whether you're in private practice or whether you're in academic practice. I would say, I think I know exactly what I signed up for. I had worked at these practice locations previously, and obviously as a faculty member, that's a very different role. But I think that I'm familiar with the system. I think the things that stress me out are trying to ensure consistency over a changing team. Whether the resident changes or the fellow changes, or you have different people available and trying to manage many moving parts. And so I think if I had to say it would be trying to be a good leader and team manager, would be the thing that I think I spend the most of my thoughts on, and trying to make sure all surgeries and non-operative patient care is accomplished efficiently, safely, successfully, and at the same time incorporating training and research as well. And one thing I would say, we were talking about preparing for practice. I did my fellowship at the Mayo Clinic, and one of the reasons that I really wanted to go there is that the fellows work with residents a lot. So in fellowship, I worked with residents a lot, and often I had residents assisting me when I was a fellow. And to me, that was a great opportunity. And I knew I was interested in academics, and I knew I wanted to teach myself how to, or have, be taught how to teach others as part of my fellowship experience.
Yeah, I think that's very helpful from both of you guys to explain that. I think, what Sandy said about stress being there, I think is real. And, we'll talk about that in some of our other talks too, about managing that and admitting to it and, not getting burned out, obviously. We have one more question here about how is basically, well, I'll just read the question. I'll give you my answer and we'll see kind of what the other people say. How is postgraduate fellowship viewed in different settings, for instance, academic versus private? And for someone coming out of a neurosurgery residency, would orthospine versus orthospine postgraduate training be viewed as equivalent in those settings? I'll tell you one thing that's really interesting. You guys have probably noticed this is, unlike 10 or 15 years ago, there's a lot more crossover with orthopedic and neurosurge in terms of spine training. I mean, at my fellowship, we had, I think, 3 neurosurgeons, and there's more there now. And certainly can teach us a lot about things that we might not otherwise encounter, like getting into the dura intentionally sometimes, which was terrifying. But so I think that skill set is certainly valued on both sides. The academic people here can chime in on this, but in private practice, when I'm hiring a partner here, and we'll be starting in, I guess, about 6 or 7 months. I don't care if that partner is a neurosurgeon or an orthopedic surgeon, as long as they want to do spine. I'm looking for the most qualified person, period. If I get along with them and we're not going to have problems covering call, and we can communicate and we can have a beer to discuss something, great. If you're in academics, at least from my experience, I can't imagine my orthopedic surgery department at UMass, and UMass is as red tape comes, but I can't imagine that orthopedic surgery department hiring a neurosurgeon for their spine team, even if they were phenomenal. It's just kind of a pride, old school issue there, and it goes both ways. So, I mean, that could certainly play into it a little bit, but there's academic institutions that have fellowships where their fellowships are neurosurgeon, ortho kind of together, and how they hire into what department, I don't really know. So, in terms of if you're talking about a fellowship, particularly which one you go to, I can't imagine it matters that much. I mean, so many fellowships welcome either or. And to be honest, if you're a neurosurgeon, maybe don't have as much experience doing a ton of osteotomies or instrumentation or whatever, for whatever reason, then, a fellowship that does a lot of those might fill some of those deficits. Any thoughts on that, Sandy or Doug, for the academic side?
Yeah, I'll just chime in quickly. I think sometimes it depends on call requirements and what the general requirements are of the call in department. And obviously every group and every practice is different, but most neurosurgery departments have, general neurosurgery call and spine call, and orthopedic call can be broken up by, spine call, pediatric call, hand call. And obviously neurosurgeons and orthopedic surgeons, as an orthopedic surgeon, I'm not taking brain call, and they certainly don't want to take general orthopedic call. So I think that's one area where one provider may be preferred over another. And another thing that doesn't maybe get talked about enough is that there can be a difference in reimbursement and coding between the two specialties. I think that is maybe a little bit more so true in academics, where an orthopedic surgeon and a neurosurgeon can be doing the exact same case in 2 operating rooms, which are right next to each other, and the reimbursement pattern is just different. Those kind of things are complicated, and those are, I think, starting to change. But I think that some of those reasons can push a group to hire one person versus another.
No, I think that's a great point. And, something Webb and I have talked about some is, what you were just explaining. If you're a private group and you hire a neurosurgeon, it's complex enough that, I was shielded from this in my training. But if I did a case with a neurosurgeon, we could bill as co-surgeons if we both kind of did equal work. Whereas if Webb and I did a case together, one of us has to bill as an assistant. And of course, the money he would make from that would be significantly less in that situation than if we were co-surgeons. So it is interesting, and hopefully that changes in the future just from a compensation perspective. Okay,
Yeah.
so I wanted to,
If you
Yeah,
don't mind, I'd just like to say one thing real quick. I think the cooperation between orthopedic and neurosurgery departments, in my personal experience, is just highly variable based on the academic institution. I think some universities have gone to great lengths to try to merge the two or have cooperative things. And I think there'll always be issues such as the call delineation. But, I would give a shout out to Emory because they do have a spine center, and have neurosurgery spine and ortho spine clinics actually right next to each other so that people can bounce ideas off each other. And I know other institutions like Cleveland Clinic as well has worked to create more of a spine service line. And so if you're looking at weighing ortho versus neurosurgery, I think both departments and both types of surgeons do great work. And just the collaboration of the specific departments, I think, is very university dependent. Okay, thanks, John.
thank you. So if you take a look at the chat box there, I think it was Megan posted the information to get CME credit. It's super easy. You were here, you just watched this and you had a beer or a glass of wine and you get credit for that. So it's phenomenal. You just text the code that she has there. You have 2 hours after each talk to get that credit. And that will work towards keeping you an employed physician if you are one. If you're a resident or fellow, then that part doesn't matter, and this part's over for you. So anyway, we're going to do this once a month. We'll send out all the reminders for you guys. Next month, we're going to talk about things you need to know for a fellowship. Here we have on the left there. So Chester Donnelly is going to talk about 10 factors to consider when ranking fellowships, which is timely for those of you that will be doing that. And I'm going to talk about 10 things to consider when choosing a job. We're going to go for the Letterman style there, hopefully equally funny. So thank you all for joining us today. We really appreciate it, and we look forward to seeing you guys next month.
Hey, John, I just want to say that you did a great job in Sandy and Webb, and what a great kickoff meeting.
Thank you.
Thank you. Good night, everyone.
Thank you, everyone. Great conference.